Hello, I'm Cindy Perlin. I'm the founder and CEO of the Alternative Pain Treatment Directory, and I'm here with Dr. Michael Cooney to talk with him about Calmare therapy. Dr. Cooney is a doctor of chiropractic. He's been in practice for over 40 years, helping people with chronic pain. And since 2011, he's been using Calmare therapy. He's one of only 7 certified Calmare therapists in the world, and he's treated thousands of patients from all over the world, coming from as far away as Australia. He's in practice in Rutherford, New Jersey. His practice is Calmare Therapy, New Jersey. Thank you for coming on with me today, Dr. Cooney.
Oh, thank you for inviting me. It's a pleasure to finally talk to you after all this time.
So tell us about what Calmare therapy is and how you got involved in it.
Okay. I got involved in it through a neurologist who worked in our office about 10, 11 years ago, and he had told me about it, and he was very interested in it because initially it was designed to treat chemotherapy-induced peripheral neuropathy, which his mother had. And he actually came in one time and told me that if I got the machine, he would pay for me to go to Amsterdam and treat his mother. So I got very interested because I had a lot of respect for this neurologist. And one thing led to another. I eventually made contact with the company, and although the machine was expensive, they decided to actually give me a machine because there was only one other person in the country doing it at the time. And they gave me the machine for a month, and then after a month, I wasn't quite convinced, so they told me to keep it for another month. And after that second month, I started to see real good results with it when I started to focus more on neuropathy patients versus neuritis patients. The neuropathies that we treat go from, as I said, chemotherapy-induced peripheral neuropathy to diabetic neuropathy to post-herpatic, which are your shingles patients, to complex regional pain syndrome, reflex sympathetic dystrophy, and fibromyalgia. Those are pretty much the big ones: sciatic, neuritis, neuropathy, things like that.
And what exactly is it?
The machine, it's a machine that creates what are called artificial neurons. And what it does is, it does 2 different things depending upon the type of neuropathy. You have 2 types of neuropathies. One where there is actual nerve damage, and that would be your chemotherapy patients, your diabetic patients, the shingles patients. And in that instance, you're creating a localized stimulation to the nerve, creating an artificial neuron going around the nerve. With the other types of neuropathy, the complex regional pain syndrome, the reflex sympathetic dystrophy, fibromyalgia, in those instances, the problem is not a localized physiological problem. In other words, the nerve is not actually damaged. What's occurring is there's a brain loop that is developed that doesn't shut off the pain signal following an injury. I liken it in most instances to phantom limb pain with these conditions, because someone will have pain in an area where there is no physiological reason for the pain, as with the phantom limb. So we treat that a little bit differently using what's called the dorsal horn along the spine, and usually at the end of the nerve that's involved. So theoretically, if someone has the complex regional pain syndrome in their lower leg, I would still treat the entire root of the nerve, trying to communicate to the brain and shut off that pain loop. And that's why it's called scrambler therapy, because you're trying to scramble that nerve or that misinterpretation within the nerve that the pain is existing.
Does this treatment hurt?
No, not at all. We don't want it to hurt. The whole idea is to decrease that discomfort level, and we don't want to create more of a pain signal which would of course reinforce the pain in the brain cell itself.
Mm-hmm. And how long does the treatment last, and how many sessions do you usually do?
Generally, it's a 35 minutes. You're actually on the machine, but we tell everybody you're in the office for an hour, and it's a 10-visit protocol. Now, this is being done, excuse me, at some of the top hospitals in the country right now, Mayo, Hopkins, and the protocol is exactly the same. It's a 10-day protocol. Some people say 10 to 12 day, but I pretty much keep it at a 10-day protocol. And the great thing about it is it's non-invasive and there were no side effects.
Mm-hmm. You're just putting electrodes on the surface of the skin.
Correct.
Mm-hmm. And, you know, one of the things that interested me about it is that the results seem so dramatic. Like you could have someone in terrible pain for decades, but they could be pretty much pain-free after these 10 sessions. Is that what you've seen?
Oh, absolutely. I've had a number of people, and you can go to the website, there's a number of testimonials, and you'll see people that have come in wheelchairs or use walkers, canes, whatever, and after 2 weeks, they're not using them anymore.
So how do you know that it's going to work? Like I've heard that you usually know really early on whether it's going to work for you.
Well, usually my general way of approaching it with people is that you have to give it at least 4 sessions. So if you try it 4 times, the patient will tell me it's working. I don't tell the patient you're getting better. I allow the patient, and we'll go through the pain scale when we do the initial exam, and we go through the pain scale basically before each treatment and after each treatment. The patient will advise me, like the last patient I had today came in and her pain level when we started was an 8. When she left, it was a 1-2. Now, it won't stay that way. The treatment is predicated in many instances based on memory. In other words, we have to retrain the brain. So I liken that to muscle memory or rote memory. You don't learn your multiplication tables in one day. You don't learn to ride a bike in one day. You have to do it over and over. And that's pretty much the reason for the 10-visit protocol, because you have to continually do it. And what we're hoping for is that when it goes from an 8 to a 1-2, we're hoping that that lower level of pain will remain longer and longer with each treatment.
Mm-hmm.
Okay.
When you say you're hoping, how often does that actually happen? Like in what percentage?
Oh, I'd say 75% of the time.
I'm sorry, how much?
75% of the time.
Mm-hmm. Mm-hmm. That sounds pretty good. So, I've heard from...
It is. And understand also that most of the patients I have been everywhere. I get people after they've tried the medications, the spinal cord stimulators, the ketamine, nerve blocks, nerve resections. So I get them. I'm the last resort for a lot of these people.
Mm-hmm. Mm-hmm. Yeah, I mean, that's what I've heard, is that the results are so dramatic in people who've tried everything else.
Right.
So are there any contraindications to using this therapy?
The only contraindications are someone that may have a pacemaker or a stent, something like that. We don't want to use, obviously, electrical stimulus on someone that has a pacemaker. We don't want to use it on someone who has epilepsy. So we stay away from those. But that's really about the list. It's a very short list of people
What
that we
about
would
the
do the treatment on.
what about the implanted spinal cord stimulators? Are those a contraindication?
No, I have treated many people that have it. Most of them will just turn it off when they come in. We don't obviously do the treatment while the stimulator is on. And it's actually probably, I could say that 30% of the people that come into my office with the spinal cord stimulator have already turned it off, because it will work generally for a short period of time, 3 months or 6 months, but after that it seems to discontinue giving that pain relief.
Yeah.
So
Yeah, spinal cord stimulators are pretty drastic. I've heard that they're very difficult to remove. You know, sometimes.
well, as you know, if you ever gotten a splinter, you know that your body starts to encapsulate it, and that's what it will do with this with a spinal cord stimulator. It encapsulates it, so the skin and everything will grow around it, making it more difficult to take out.
Yeah, I mean, I would like to see more people know about Calmare therapy, so they do that before they go to the point of getting a spinal cord stimulator. And as I understand it, the stimulator is really just a distracting signal. It doesn't really fix anything.
It's not much different than a surface TENS unit.
Right. Right. We keep losing your video there temporarily for some reason.
Yeah.
But you're back. Yeah, so can you talk about some specific patients that you've worked with who have had good success with it?
I've had, well, as you said, I've had 1,000 patients, and I've treated everything from the chemotherapy patient to the diabetic patient to my primary practice is complex regional pain syndrome, and it's been very successful with that. I'm treating patients right now from Texas and from Maryland. So people travel. It's harder now because of the COVID situation. I've had a couple of Canadian patients that want to come down, but they obviously can't get into the country right now because of what's going on. But it's so variable with when you talk about patients and their presentation, because someone could come in and just have pain in the lower leg and foot, and some people can have full body pain. So the way you treat them is determined on where the pain initially started. So we always try and treat the initial injury, and generally that will help with the spread. That's one of the reasons I believe, because no one really knows or has any, there's no objective test to determine these diagnoses. The diagnosis is predicated on just the symptomology that they present. And if they have a number of the associated symptoms, then we'll make that particular diagnosis based on their presentation.
Right.
So we have to listen to the patient very carefully. It's more the communication that leads us to treating the right nerve pathways.
Yeah, I think one of the troubling things about pain is that nobody else can see it. You're the only one who knows where it is. And the pain scale has been criticized because it's so subjective, but pain is a subjective thing.
Sure. And what's a 5 or 6 to you could be an 8 or 9 to someone else.
Right. So on average, how long have people been in pain before they come to you?
Oh, usually it's 2 or 3 years.
And sometimes it's much longer.
Oh, I've had people that have had it 20 and 22 years, yeah.
And in 10 days or 10 treatments, it's gone.
Oh, sometimes it takes longer. Like one patient that had it for 20 years, he came to me and stayed and had 22 visits. But the only time that we go beyond the 10 visits is if the patient is showing progress. So if he is coming in for, let's say, the first 10 days, and we've taken him from an 8 or 9, and now he's down to a 3, let's say. If he's showing progress each day, we will then continue to go beyond the 10 visits. There are certain patients, however, that they'll come in at an 8 or 9, and after the 10 days, they're at a 3, but they've been a 3 for 3 days in a row. And that may be the best we're going to get. But with most of, I just had someone recently who was ecstatic getting at a 3 because now he could play golf and now he could, work and do his job, and he wasn't taking the medication, which is the most important thing to me, because the medication is doing damage.
Mm-hmm. Mm-hmm. Do you suspect that with people who can't get lower than, say, a 3, that there might be something else going on, like a nutritional deficiency or body
that's
mechanics?
quite possible. That's quite possible. Yeah. It could be nutritional. It could be a biomechanical problem going on, the soft tissue problem going on. I definitely work with physical therapists and the like to try and rehabilitate, because most of these people will have certain atrophy and malfunction within a particular joint because they haven't been using it because of the pain. So they need rehab, and I don't do that. But if we can get your pain level down, then you can do the rehab.
Right, right. Now, once people are, as better as you can get them, and sometimes it's down to 0, I understand.
Right.
Do they ever need boosters? Do they need?
Yes, yeah. I would say probably 40% of people will need boosters. But what I tell them, and let's take the patient that started at an 8, and let's say it's one of those ones that we're very successful with, and they go to a 0. I tell them if 6 months from now or a year from now, if it starts to go up to a 2, 3, to come in right away. Don't let it get up to an 8, 9, because if you come in right away, you will only need anywhere from 1 to 3 boosters. You won't have to go through the whole protocol all over again.
Mm-hmm, mm-hmm. I know what's most in people's minds as they listen to this is, does insurance cover it?
It's starting to. We've had some successes with some insurance companies. It depends on the insurance company. And what I do is I give the patients what's called the CPT code, the treatment code, and they can check with their insurance company. Ironically, following presentation to the insurance company, even if they deny it, we have some material excuse me, that we send to the insurance company showing them the validity of the, but we're seeing more and more, like the VA is starting to cover it, and the funny thing is that the federal government is buying something like $2 million worth of machines. But the
Calmare machines?
Calmare machines, yes. And but the federal government won't pay for it through Medicare, which is like contradictory. But that's not unusual with the government, I guess.
Well, sometimes, each agency makes its own rules.
Sure.
Yeah.
But ironically, well, here's one that's interesting. Medicare was sued by a patient to pay for the Calmare. It was a chemotherapy patient, and Medicare lost. They had to pay. So we, in the Calmare community, were ecstatic, believing that now would open up Medicare to Calmare treatments. Medicare turned around and said, oh no, we lost this case, but it's only that singular case. We don't have to put it in as a treatment code. So we're still fighting them on that.
So if someone can't get insurance coverage, how expensive is it?
It's $3,500 for everything, consultation, exam, and the 10 treatments. That's all inclusive. Which,
So
when
if
you
people,
talk about some of these pain patients, is it may sound like a lot, but when you talk about a spinal cord stimulator or ketamine, you're talking $60,000, $70,000, $80,000.
yeah, and as I understand it, the spinal cord stimulator, the ongoing costs are in the hundreds of thousands of dollars.
You have to be tested. You have to make sure that the batteries are working. You have to make sure that the leads don't come loose. I've had patients that have told me they were burned because the leads came loose.
Mm-hmm, mm-hmm. And then that involves more surgeries, right? When that happens?
I would think
When
so.
you need a new battery. I had a client come to me and his battery was going dead and he was going to need a new surgery. And if they wanted to remove it, he had a dorsal, whatever, spinal cord stimulator. They told him it could paralyze him if they removed it because it was embedded in the spinal cord or whatever.
Oh, sure.
So this is, people, one of the reasons I started the Alternative Pain Treatment Directory is to hopefully divert more people from these, really invasive, risky procedures to things like Calmare therapy that's so much less risky. I mean, the worst that can happen is it won't work.
Exactly.
It works for most people.
That's in many instances, there are people that are very skeptical because of all of the treatments they've tried and haven't worked. So I have no compunction against telling people you want to come in and you don't want to pay the full cost of the 10 visits, then pay for the 4 visits and make the decision yourself after the 4 visits if you want.
Mm-hmm. So they don't have to commit to the whole amount up front.
Right. Yeah,
So
I don't take people's money if it's not working.
Yeah.
And as I said earlier, I don't make that decision. They tell me if it's working.
Mm-hmm. Mm-hmm. So how many other therapists who do this are there in the US? I know you said there's 7 certified therapists, but how many are there altogether?
There's probably, I don't know, there's probably 25 or 30 hospitals that are doing it now. And there's probably about the same number of people that do it, but there's only, it's probably a little bit more now. I think there may be 10 certified providers now in the country.
Mm-hmm.
And the certification is predicated upon having done case studies and presentations back to Rome and showing treatment protocols that you've used and having it evaluated by them in Rome, and then they give you the certification.
Mm-hmm. Mm-hmm. So if somebody wanted to get started with this, I know some people come from great distances. Do you do some like phone screening or something like that ahead of time?
I vet everyone before they come. I talk to every patient before they come to the office, primarily because I want to make sure that their diagnosis and their condition is compatible with this treatment, because there are many people that will be given diagnoses that aren't really neuropathies, they're more neuritises. And I have to be able to talk to the patient to determine just a simple question like, do you wake in the morning with pain?
Mm-hmm.
And if the patient says no, but, excuse me, but after I walk around for an hour, my back and leg are numb and in pain. Or after I walk, my foot is in pain. more than likely that's a neuritis because there's some sort of biomechanical or soft tissue problem that's causing pressure on the nerve. A simple example of that is a disc problem. So when you wake up in the morning, you've been laying down all night, so there's no direct pressure on the nerve, or on the disc rather, hitting the nerve. But then as soon as you go into a vertical position, your weight is starting to bear down on that disc, and it puts more pressure on the nerve, consequently pain.
So this therapy isn't going to work for people like that?
No, we don't treat neuritis, just neuropathy.
So what other conditions wouldn't it work for that people might have?
Well, any of those conditions that fall within a biomechanical or structural area, you know, if some people might have tennis elbow or, you know, things along those lines where it's really a ligament or soft tissue problem. That doesn't come within the treatment regimen for this, for the Calmare.
But certainly a lot of people have conditions that it is going to be very helpful for.
Right, and as I said, that's my job, to vet the people when they call, and I speak to everyone before they come to make sure that it is a neuropathy and not a neuritis or any other condition. You know, some conditions are very subtle and very serious that could present something like a neuropathy. Something as serious, let's say, as an MS or some conditions like that, that will present as a neuropathy. But there are usually some indicators when you speak to the patient that give you an idea. And in many instances, the people will have had the blood test and MRIs and things like that. Most of the people that come to me have the full screening. They've had MRIs, X-rays, CAT scans, EMGs, blood work. So most of those other conditions can be ruled out.
So it wouldn't work for MS?
No.
Okay.
No, there's demyelination of the nerve, and it's not a neuropathy. That's more of an ongoing damage to the nerve that you know, could be treated. You know, there's obviously medications and such, and you know, vitamin B is very big for.
Yeah,
MS.
that's a progressive condition, so I suppose that makes a difference. So is there anything else that you like to tell people that they should know about Calmare therapy?
Just the fact that it's non-invasive. There are no side effects. We will ensure that the likelihood is that it will help you before you make the effort to come in. And as you said, I've had people from all over the world, from every continent, as a matter of fact. To name a continent, and I've had them as patients. And we have a big map in the office that we put pins in for people that come from unusual places. So I just had someone not too long ago from Tasmania.
Wow.
So.
Well, it's, you know, chronic pain is such a difficult, complex issue. And as you said, many people spend many years and, you know, tons of money looking for something that will work. So, you know, as I said, I was very excited when I read about this because it's just, you know, it just seems pretty amazing, almost unbelievable.
Well, I mean, that was what people said in the very beginning when I started doing this. And then what happened was, as I guess it was about the third or fourth year of me doing it, all of a sudden, the major hospitals started utilizing it. I mean, even for cancer patients, probably the most prestigious hospital is MD Anderson, and they're using this now. So, I mean, you can't get much better than that, besides obviously Mayo and Hopkins and places like that. Walter Reed, Massey Cancer Institute, the list goes on.
Yeah, that's great that it's being adopted by mainstream hospitals. And hopefully, I wonder if they're doing better getting reimbursement, because usually hospitals don't start offering treatments unless insurance companies are willing to reimburse them. So it would be an interesting question.
Right.
So how can people get in touch with you?
They can go to my website, which is Calmare Therapy, NJ for New Jersey.com, or they can call the office. I can give you the telephone number. It's 201-933-4440.
Can you repeat that again for anyone who didn't have a pen in hand?
Okay. 201-933-4440.
Okay, and also people can go to my website, paintreatmentdirectory.com, where you're a listed provider, and also get your contact information.
Right.
And for anyone who has chronic pain that isn't in a category that this therapy can help, or can't get to New Jersey to do it, you can find other alternative therapies that are safe and effective on the Pain Treatment Directory, which is paintreatmentdirectory.com. So thank you, Dr. Cooney, for
thank you.
taking the
You
time
do
to talk
wonderful
with me.
work. You do great work. So
Well,
I'm
thank
happy
you.
to
You
be
are
part.
too.
Thank you.
All right. Well, you have a great evening, and thanks again for joining me.
Thank you. I appreciate it. Bye-bye.
Bye-bye.